So we're going to go ahead and get started. Dr. Artz, I think, is off taking a call maybe, and will be with us in just a second. But I wanted to answer this question first because it's sort of for the panel, but not. It says, are any hospitals changing patient menus to follow what we are talking about? Why or why not? Tomorrow's programming, this is what tomorrow's programming is all about. And we'll have some announcements about some of the work that the Culinary Medicine Specialists Board is doing in the food service arena. And then we will also be having another event that I'll talk about a little bit more tomorrow. Mark your calendar. On September 19th, we're going to do about a 4-hour webinar on this very topic. We have some renowned chefs, executive chefs from across the country, as well as behavioral psychologists, et cetera, that address exactly this topic. So, it's like I planted this question for tomorrow, but I didn't. I'm going to start off throwing stuff around. I'm going to start off, there's just a lot here. It's almost really difficult to start. I'm going to start with, and there's a little bit of different focus between our media piece and our clinical piece. I think one of the things that I would like to ask is, for both Kristi and Jaclyn, how much promotion have you guys done? What is your relationship right now with your PR department? Maybe sharing some of that of how you got to maybe Joette, because I know you guys have got a lot of press, and so have you. How's that happened?
We definitely work closely with a designated PR person through Spectrum Health, and they often will contact us for media outreach in terms of articles where they need a quote, or they'd like to submit some information around nutrition topics, for example, how to support immune system through COVID, if it's cardiovascular disease month. They'll often reach out to us. So we've developed a very, I would say, close relationship with our PR team as well as our marketing team. And so I initially did not realize those were separate departments. Mm-hmm. So I think that's an important thing to recognize, is that they have different areas of focus, and getting to know those teams individually and what their needs are, and in particular with the PR team, they usually need that quick turnaround within 24 hours or 48 hours, and so trying to be able to get back to them right away. I know Elizabeth Suvetti on our team, she does quite a bit of media work locally, so we certainly try to identify team members that are comfortable being on camera, that enjoy that experience. It does take a lot of time and effort. So we try to organize it around activities where we're promoting enrollment, or if we have a new program that we want to have the community become aware of. Those are oftentimes the times that we'll seek out those opportunities as well.
I just briefly add that we haven't sought it out a lot, but I did form relationships with our PR team so that they come to me when, an example, U.S. News is doing an article on something and they want a comment or an example from us. Or one of our local magazines, D Magazine, came and wanted to do a story on us, and we did that. I think that you need to know the culture of your institution. I work for the state, technically, as a state university faculty member, and so there's some limitations to things. I also am engaged with our government relations people because sometimes I need to clear through them my engagement with things. There are times to ask for forgiveness later, and there are times to stay out of trouble. And when you're building a new program for which you're trying to get buy-in and support, I err on the side of staying out of trouble. And so do know your own culture and of your institution when you get involved initially.
So I'm going to kind of stay with that theme on your end just briefly, Joette. What would appeal to you? Like, what sort of pitch? I know you said a few minutes ago when we were chatting about this that folks needed to be specific. Like, what do you have to pitch to your producer?
Related to nutrition, or it's related to something that you're doing, that's a really great time to what I would be looking for. I'm looking for something that's got a lot of community engagement. We like doing stories where we're going to see a lot of, again, we're going to get a lot of visuals, so the cooking, the individuals in the kitchen, all of those things are very, very attractive.
So the visual piece also. So these two questions are related. I think they're both for Dr. Albin and Dr. Artz. And it really has to do, they're almost identical, so I'm going to read this person's question. When trying to appeal to a value-based system full risk, have you all found that there's any appetite for culinary medicine and lifestyle medicine? And I know you guys are getting more, we were talking last night at dinner, that y'all are getting maybe to as much as 50% risk in the next few years.
Right. So yes, there's definitely an appetite, but it doesn't mean that there's a clear path or that the path will be apparent to you right away. So you, of course, need to build your case. What is the ROI? How will it be measured? How can you demonstrate patient outcomes that are meaningful to the organization? And also begin to understand what value-based care means. So I actually spent the last 6 months doing an executive education course through Hopkins to really understand value-based care. And again, it's a lot about educating yourself around the terminology, what's meaningful to organizations, how do you drive value, and then being able to align your programs to drive those outcomes. One example I'll provide is we have value transformation occurring in our orthopedic spine space. There's a huge need for culinary and lifestyle interventions, and that's an area where if you can help others, other physician leaders, executives understand the value of applying culinary interventions to a prehab space for an individual, getting them toward a more anti-inflammatory diet with weight reduction and joint pain improvement, that's meaningful in a value-based environment. So think about those opportunities.
Jaclyn?
Well, not a lot to add other than just go reach out to those people. If you know you have an ACO, it's often in the quality office. And our quality people, they live in a silo, and they don't even know what's going on. And so sometimes I go to them and say, what's even the deal right now? What do you need? What are your pain points? And that's when I learned, we don't know how else to save in diabetes. And so that doesn't mean they've jumped on the bandwagon, but at least they're listening.
So these are two similar questions that kind of segue. It's not just about value-based care, but it's kind of the general approach to getting your sites on board. There's one that specifically asks about academic medicine, but what strategies did you use to have your institutions approve and provide financial support needed to create your programmings? I know, Jaclyn, you said you hadn't had very much, but I think the sort of follow-on question to that for both of you is, what are the common concerns or hesitations that leadership may pose? So what roadblocks are they putting up when they're putting up roadblocks? I think us all hearing that, maybe we begin to think about how we overcome those roadblocks.
Well, I'll just start by saying it's very difficult to get funding at the medical school level unless you can get it at a high up level, like a dean's office, chancellor level. And I actually am excited that a team that I worked with is publishing a review of U.S.-based culinary medicine programs for medical students. It will probably be out in a couple of months. And we went through funding structure of every program that we could find and listed the source. So you could say, look at all these schools that are getting money from their dean's office. And I think that's the way we have to do it right now. It's grassroots. I paid for the food myself sometimes. And fortunately, working with Millette, who works for a cancer foundation, there was some funding of her time. My time is not protected for any of the educational work I do. It's a passion project, and that's why we have to expand. I will say I've had great success negotiating payments from GME programs. So when I got the love from the medical school, I said, okay, we're going to cap out what we do at the medical school level because they don't pay for it. And now I'm going to go to pediatric GI. They want classes. Family medicine wants classes, and so forth and so on. And I say, this is how much I a charge. Here's what you're paying for, and no problems getting some of our costs offset through GME payment. And then the costs from any educational program can also sometimes be offset by research grants that you can spill over. So you have to sort of figure out what your pot is and where can you get money that's flexible. And it's such an iterative process of meeting the needs and being flexible and adaptable.
On the delivery system side, I would say you have to understand how to create a business pro forma, the P&L. You have to really understand what your facility costs are, your operational costs will be, and factor that into all the conversations that will lead into support or not for your department. So we did about an 18-month stakeholder analysis. It was quite a comprehensive process that ultimately led to the creation of the business proposal. And we've recently gone back and looked at how are we tracking on those KPIs, so those key performance indicators. So those are some of the other terms I would encourage you to become familiar with, because that's what you're going to be measured against. And then looking at reimbursable strategies, so shared appointments, e-consults, remote monitoring. These drive reimbursement models as a system's moving towards value.
And there's a scad of questions here that are all very related to that coding, basically. And again, I promised the group we will have more updated information on billing and coding as it relates to shared medical visits, et cetera. So, what are y'all billing at? Are you billing level 2, level 3? One person says, I bill, strictly by time now. Can you bill a level 5? I mean, what's the advice that you guys have maybe from your billing departments, or what sort of advice did you get from the compliance folks?
We have not, we were actually recommended to not utilize time-based billing, to rather use problem-based billing. So for our new patient, we bill as a specialty service, and so we oftentimes will bill 99214s for new patient visits, occasional 5s, but that's quite rare. And then for the vast majority of our SMAs, it's 99213s, as well as for our established follow-ups, and we do problem-based billing.
My group visits have all been community pro bono based, like grant funded and or not funded. So we have not yet launched our SMAs. That's happening in partnership with one of our community sites this fall. And to speak to Dr. Artz's comments, we were told by our billing team that if we pay a facility fee by the hour, we can use a community site to run the classes, and I can bill in that context. And so 99213 is definitely the comfort zone. Some people are billing 4s, but they get some experiences with it being kicked back, and I would rather not deal with all that on the back end. I think if you pack a class out, 99213 can be productive.
Yeah, and currently, in the current version of the billing and coding module, it does go over a lot of that. There's some resources from Blue Cross Blue Shield there. There are also, the guidelines that we provided are, you really don't want to go past that level 3 visit. It will trigger, you do that a lot, it's going to trigger
scrutiny.
An audit. Yeah,
no one wants scrutiny.
Yeah, it's going to trigger an audit. I think this question actually gets to, and maybe I can help clarify what you're saying. It says, can you bill if chef or physician uses their own kitchen? The term that our billing and coding colleagues use and that insurance companies use is site of service. So if you don't have an established site of service, then you can't bill for a particular service. And that site of service is, generally speaking, our clinics, sometimes our hospitals. Maybe we have 3 or 4 or 5 clinics in a particular system that are around town. So if you want to do this, you have to, and you're in a big system, you have to speak with your compliance department and get them to establish that location. Even if it's going to be an ad hoc or a contract location, it really needs to be established as a site of service. Because technically, if you bill it for your clinic and you hold that visit somewhere else, that is technically, I guess it would technically be fraud. It's maybe not, it's indirect fraud. And this one asks about the hour-long 99215 visits. I do a lot of level 5 visits, follow-up visits in my clinic, doing one-on-one counseling with patients, and I think that helps me with my RVU-based system. There is a question here about what do you do if you're just an employee? Any ideas for that? Not really an RVU-based person, but just an employee of a particular entity. Any ideas about that?
Again, I think I spoke to the idea of financial alignment. So if you're, for example, if your employees and your health system or your practice, if you're self-funded for your employee health piece, that's where there can be financial alignment. Similarly, if it's in a larger organization, you'll want to look for that. You'll want to look for risk contracts. You'll want to look for market share of a particular payer. And all of these things, it's sort of the dirty underbelly, I would say, of healthcare, but we need to understand it if we're going to be successful in these new models of care. Those would be the recommendations.
I would just say, just like what I have been doing is, okay, if this is the normal amount of RVUs that I produce in a clinic session, how many e-consults do I have to do a month to drop either one a week or one every other week? You could do the same thing with revenue. So you just do some, see what the revenue looks like, and then you can cancel it out gradually. And right now, I actually haven't dropped any clinic yet. I have just spit them in, kind of in the corners. And as it grows, I'm getting ready to say, I need to negotiate that this time is now protected to do these.
So I'm going to ask Joette this question. I really like this question a lot, and I have struggled with it myself. Very straightforward. How do you get over the fear of, quote, imposter syndrome, end quote, the fear of being judged by experts and other specialists that maybe you are not expert enough, but you end up on television? There's that fear that I'm not worthy of that piece. Ideas about that?
Yeah.
Maybe you went through that a little bit?
I did. I shared that. I was concerned also, what are my colleagues going to think? I'm talking about this topic, and I'm really not an expert in this, this little tiny niche of this particular specialty. But again, they're looking for doctors, and doctors have a lot more information. And again, they always told me that when I first started. You know more than the viewer. You're going to know more than those individuals at home. So really giving your expertise, filling that void, and being a person who's affable and available. And again, it's like she said, there is a very quick turnaround sometimes. If they need someone, they need them now. They'll need them in the next hour or two. There's something called MMJs now. So these are multimedia journalists. And what they do is everything. They do the interview. They videotape it. They have to cut it. They have to edit it. And they have to get it on air. So they need responses that are very rapid. And once again, keep it simple. You don't need to do a dissertation. I think the first time I was on air, I thought that I sat there and I did the same kind of research that I would have done at my Superfund site. You don't have to do that much. Certainly you want to be up to date. You want to look at the latest journals, and you want to scan the literature and know what you're talking about, certainly. But you don't have to be an expert in that particular field to give commentary. And I apologize, I didn't get to show that one video. We're going to put it online. But it shows this neurologist looking at a video of this particular person who had frontotemporal dementia. And he basically kind of emotionally says, this looks like a person with no emotion. He's not giving us a medical diagnosis, but he's giving us his interpretation of that person.
I just want to briefly add to the imposter syndrome thing that it never really goes away. And I tell my residents that all the time. I'm like, you never arrive. But if you proceed with authenticity and integrity and humility, it's okay. And when you start speaking out more, people will disagree with you and people will be mean to you. And I think it's easier to hide in the corner. It is. Like, none of us find this easy. And so I would just say, put yourself out there, and then make sure you have your cheerleading squad who will honestly tell you where you went wrong, how to do better next time, and then just be humble and human, because we're all just trying to do our best. And then remember, there are lots of voices out there with no credentials. You have credentials, so you have something to say, and it matters, and it doesn't have to be perfect.
Yeah, I think one of the things that I've done through the years is I have made certain that people know this is my opinion. I often say to patients, I can line up 10 different cardiologists. You might not get 10 different, answers or to the question, but you're going to get 3 or 4. I think it's a challenge in our practice to make sure that you're getting the right answer, because the right answer for that particular patient may be very different from the other patient. Kristi, any ideas about that? Any ideas about feeling like when you're on being interviewed, et cetera?
I agree. It's ongoing. It never ends, but I think you build confidence over time. I think to the developing relationships with your marketing team, I think that's been really helpful in our line of work. And there's actually one reporter who has done so much work with our team. Most recently, he reached out and he said, I'm going to submit this to you. I'm going to answer these questions. I think I know your voice now. And I was like, wow, that's super cool. And I made a couple of edits, but it was a super quick turnaround. So I think a lot of this is just about relationship building. And there are going to be people that have better skill sets at certain areas than you do. And when they do, work with them. Let them enable your work.
So back to a few kind of logistics type things. One is how often are you doing your SMAs? I mean, is it a weekly? Is it every other week? How do you have them sign a contract, or are they signing up for a package? How do you?
From the patient side, I don't know that they see it as something different than just how they receive care in our
But
department.
how often do they come? Do they come every week? Do they come every other week?
Right. So the Cooking for Health program, they come every other week for 8 weeks. And other programs, they come once a month. But in our practice schedule, we are doing so many now that actually our amazing intern that I referred to earlier, she sets out a shared medical appointment schedule in advance every 2 weeks so that we are viewing upcoming shared visits and we all have sight who's on point, who's doing what, because it gets quite complicated when you're running them multiple days a week.
And do either of you guys use pre-recorded content for these types of programming? You're not using, is it all live? It's all being done in person?
Certain programs we have patients review video content prior to the visit.
Do they do that?
They do.
Do they really?
Yeah. We've actually tracked like homework, if you will, and they mostly do it. Yeah. It's amazing.
Yeah.
Well, and things happen. So an example of if Millette suddenly is not available to be the culinary dietitian for a session, she has a YouTube channel of cooking videos, and that would be what I would do. I would play one of those, and then I would teach them something super simple because I don't have the same culinary skills that she does. And so you can have that content over time to be able to improvise, which I think is helpful.
And I think this is a pretty interesting question because I think that our normal doctor's hours are oftentimes a problem for our patients. It says for both presenters, Albin and Artz, are all of these visits during standard office hours, and does this create a barrier to access for certain patients? And do patients mention that in their feedback? So nights, weekends.
We offer Cooking for Health from 4 to 6 p.m., so we do try to reach non-traditional hours. One of our other more comprehensive programs, it actually runs from 6 to 7 p.m., so yes. We're doing it in hours that people can really attend those visits on a regular basis, particularly if there are those longitudinal programs. One of the advantages, I would say, of virtual work, and I've been thinking about this a lot more in terms of licensure across the state lines, is that we could potentially grow teams where you could have a coach or a dietitian, depending on how your compliance teams view it, who might be situated on the West Coast and you're on East Coast time. There would be huge advantage to doing that, so you could reach people. That's their regular work day when everybody else on the East Coast is, finishing their day. So I would encourage you to think about that disruptive innovation. I think that would be one way to approach it.
So we're doing a study right now that is grant funded, and it's looking at culinary medicine classes versus traditional nutrition visits in a Spanish-speaking population with diabetes in our area. And we actually, in round one, had a lot of difficulty with people attending or coming up and showing up and knowing they were supposed to cook at culinary medicine class. And initially we thought, okay, maybe this is bad timing. We shouldn't be doing it. We were doing it at 6 to 8 p.m. And then when we did a qualitative study, they wanted that time because they were like, yeah, we'll have dinner ready, 7:30 in there. That's good timing for us. But the reality was that they didn't understand what culinary medicine was. And we realized this doesn't translate well to Spanish. So we had to get our Spanish-speaking chef and several other community members involved to say, how do we market this to a Spanish-speaking community, recognizing that culinary medicine isn't semantically normalized in Spanish. And so what do we need to do to culturally translate is part of the battle, and it's just a painful learning process when you do it on the upfront side. But I would say we have classes at all different times for our students, sometimes in the morning, sometimes at lunch, sometimes in the afternoon. The students and residents don't love it when they come to evening classes because they want to be done, and this is considered school. And, this is part of their learning. So actually our residency programs now protect their time, so they come from 2 to 5 for our resident classes. The student schedules are not flexible enough to do that, so we end up, because we're not integrated into the curriculum as an elective, so they actually come in the evening. But if you can integrate it into the curriculum, the afternoon is super popular for learners.
Yeah, I think the other big question here is, did you charge at first? So did you charge for these classes, or were they free when you started out? I mean, how did you guys start up with that?
We've always had different arms of our program, so we really got our start with grant funding and received a significant amount for a 2-year program, which was all free to participants, and we actually were able to receive refunding from the same organization, so it's been an ongoing 4-year project. So those are all free classes. We do have community-facing pay to enter into the class, and those at times, it varies on when they're popular. Sometimes they are, sometimes depending on the time of the year, summer, holidays, people kind of dwindle a little bit. So think about that too when you're planning your programming. When are people going to be distracted by other events in their own lives, of course? And then when you're doing shared medical appointments, there's a copay typically. So you'll want to consider that as well. Is that a barrier to the patients that you're trying to serve?
It's actually a question in here about whether or not you're getting pushback from patients about the copay for that visit.
Well, so we have not yet charged. I will say that when my passion is to make this successful in the more food insecure communities, and some of our classes will always have to be free because of lack of insurance in some of those contexts. But our patients in that population who have Medicare or Medicaid or private insurance, they have, on our discussions about this process, they have said, well, is it going to be the same as what I would pay if I just came to see you? And if the answer is yes, which it is, most of them are cool with that. They're like, okay, I got to see you and I got a free meal. So they're okay with it for the most part, but I'm sure we will continue to learn. And I want to add, if you're building it in a community context and it's a community that is not wealthy, one of the key aspects is getting community leaders. We have a community advisory board, and so we've been planning classes with them to come and tell us what works, what doesn't work, how is this going to go over with your populations that you serve, and then letting them direct some of the approaches that we take. And so I think it's just listening and being willing to change how you do it. Am I going in and out?
But there's people not here. There's people in Germany. who can't, you're not that loud. Or maybe you are, I don't know. I will say at Tulane, we never charged. And some of that is the benefit that, building a teaching kitchen at a medical school, I mean, that was my dean's idea. It was not my idea. And, having the support of Ben Sachs in the dean's office to make that happen meant that we had, and part of that brief and the sales pitch that helped us get the philanthropy to build that teaching kitchen surrounded that we were not just going to teach the medical students and the residents how to cook, but we were also going to teach the community. That was baked in from day one. And so at Tulane, they're still not charging for community classes. At GW, we have a lot of the same support from the dean's office and actually from the university in general. And while we're not endowed, we have some runtime on our funding now. Our plans are, we're knock wood, going to have our kitchen open in October, and our plans are to probably start doing shared medical appointments out of the box. But I agree that we're always going to offer programming for free. I mean, that's baked into my psyche. It may be something that other people are going to have different opinions about that, but that's always going to be baked into what I do. That's not working at all. Maybe trade.
There's a time and a season for everything. Okay. There's a time and a season for everything, right? So you just have to find what fits the situation. But I think that we have to say this is just as valuable and probably more so than your appointment in the clinic. So this is worth getting reimbursed for. It's worth getting paid for. And that's part of the message is that we're offering value that exceeds that. I mean, all of you have been to a useless medical visit, right? I'm not going to hide under the chair. Sometimes I give useless medical visits because I don't even feel like I can help. So when you do something like culinary medicine shared medical appointment, you are offering so much value, and we should be proud of that and able to ask for reimbursement for that. And we have to stop feeling like, well, here you go, it's free, it's free, it's free to everything. Like everything we do free for the educational systems. That's why I got aggressive about making the graduate medical education programs pay. So just don't forget you are offering value, and so you find the right audience who will be able to use insurance and pay.
Do you want to talk a little bit about it? Because I know early days you did work in sort of not really the workplace wellness piece, but you did a lot of team building with departments on campus, and they paid you for that.
Yeah, actually, that was when we first realized, oh my gosh, people will pay for this. It was, I think, was it our marketing team that came first? They reached out to us and they said, we kind of want to learn about what you're doing. And that's another message I would take away is there's so much negativity in the news and everywhere else. This is a good story. This is a happy story. And actually, I met with our government affairs people who were in the middle of dealing with a crisis that, there's like a lot of political crises in the state of Texas these days and that affect the health system. And when I met with them, they literally said to me, the VP of Government Relations said, this is so refreshing. We'll talk to you anytime because we would love to support your advocacy work because it's so much more positive than everything else we're doing. And so utilize that and recognize that they want to learn about what you're doing. So we invited the PR team, we invited the deans and the medical school stakeholders, and all of them were willing to pay us for a class as team building because they also, and now would be a great time to pitch those things because everyone misses each other, and depending on your local rules, everyone can throw a mask on and then spread out while they eat, but offering this class as team building to the different departments on campus is a great strategy to roadshow, as Dr. Artz calls it.
And we do ongoing provider wellness work. So if you do have a provider wellness department in your health system, I would engage with them, find out what programs they're offering to the teams. We do have a very clear price point for each type of, whether it's a presentation or a demonstration or a full culinary medicine class. So have a variety of offerings with different price points to groups that could actually purchase and pay for those services because we don't want to undervalue the work that we do. I think there always will be a role for free community classes, but define your population to which those classes are made available. For everybody else, this is valuable work, and you need to know what the cost is. So get your true cost based on all the efforts and time and people resources that go into it, and then give a true cost that we found that employer groups as well as the team building experiences will pay for.
And for those of you who might be interested, I'm happy to get on a Zoom call with you. We did a lot of work at Tulane in the workplace wellness programming for the university. So I was Associate Dean for Clinical Services. I basically was Medical Director for the faculty practice, and the workplace wellness clinics at Tulane rolled up to my office. And we had a lot of very innovative programming that was very much lifestyle culinary medicine based in our workplace wellness clinics. Sadly, because that was a benefit it's part of the benefits program from the HR department, and that's subject to ERISA laws. I can't actually publish those data, but I'm happy to share those data with you guys and show you, if you want to reach out to me, how to think about integrating culinary medicine into a workplace wellness programming that may be pre-existing at your university or at other companies. So testimonials. That's the question. Do you think, and I'm going to ask you guys about what you think about testimonials, and both of y'all are building your marketing strategies, et cetera. You've got these patients, they come, they do this programming. Most all of them rave about it. I mean, how far does that go for us making a pitch to media to market ourselves?
No, that's wonderful. We love that. Like I said, we really like talking to people in the community, seeing those changes, watching them occur. And, I had the luxury that I could do that over time. So I could interview them before they begin, during, and then after. And then just seeing those results, seeing the passion. And again, it's all that authenticity that you were talking about, just the authenticity of the program, of the people. And again, and I just want to say one more thing. It's okay to say, I don't know. If someone asks you a question and you don't know, it's okay to say, I don't know. Or, we're studying this or we're moving forward. But yeah, I think we did 2 stories with your program. We did one with your program, remember? I think I shot it myself on my cell phone. And then I did another one here at UCF with Dr. Karch. And we highlighted the program, and I got to tell you, the supervisors and the news directors love that.
On the implementation side, though, this is another project, right? So understand that if you're going to have patient testimonials, you have to create an Excel document, right? And someone needs to manage it. So every month, we actually send out an email to our team who's had a great patient story, and we have a secure place where that, HIPAA information is saved, and so we can call upon it when we get PR requests or if we want to pitch a story to someone. So just realize it's another piece of work.
One workaround is to use learners who are there. And so if you can get the medical student who was at the community class or the SMA whose life was changed, and they come in and, I have students who will come out and say, this changed my whole career trajectory. And actually the media was going to do a big piece on this one particular student, and then COVID exploded again, and they did a COVID story instead, and I cried. But anyway, it's another project, and I also just want to say we as physicians in particular are biased towards data, and I had to get over that bias and be like, okay, the anecdotes matter too.
That's a really good. It's a really good point, and I'll post a pretty fascinating article. It's a review article about qualitative research in nutrition, and that we're not doing enough qualitative research. I mean, and again, I'm an evidence-based physician. I believe in true evidence, but there is that qualitative piece that has us understanding what our patients, what folks need, community members need better that you can't get from a randomized trial, right?
Right, and I often think we're measuring the wrong things. I think we need to measure human flourishing and how everybody's doing day to day in their lives, and it's hard to capture that with biomarker changes and very discrete data points. So you need all of it, essentially. So you can tell the story, you can do that user-centered design, you can have your composite patients. You need to just build these databases so that when you are trying to, and then who your audience is. So I think about that every time a presentation, request comes up. Who is the audience? What data can I pull from? What are they going to be most interested in? And when you have all of that at your fingertips because you've done the legwork to think about, creating this database, it really becomes what you draw upon time and time again.
So as we're getting ready to close out, I want to let folks know there's a lot of questions here that we're not going to answer, but every one of them, I think, is fabulous. And our plans are, as I said earlier, is to take both of these lectures and create white papers around each of these ideas that are roadmaps of how folks can deploy it. So there's a lot of questions here that are very, very specific that I actually would not want to answer myself. One, can you use SMA for family groups where multiple members of families participate in shared visit, and can you bill for each member of the family separately? Do you know the answer to that question?
I could, because I see adults and children, and I've actually pitched it that way. I said, hey, we can do family class, mom, teenager, grandma.
Your compliance?
Haven't done it yet.
but the question is, what's your compliance department going to say?
Well, I see patients in that context in clinic every day. I see babies, I see 90-year-olds back to back.
But you don't see them in the same room, right? And
I think you have to prove success on either side. Right. And remember my walk through the open door? I actually tried to do this on the peds side first, and that door wasn't as open as I wanted it to be. And so I walked through the adult door. And but I think the peds people are going to get FOMO. You've got to, the missing out fear is real with this work. And as soon as you start doing it and everyone talks about how fun it is, they're like, oh, we want to try that. And so then all the barriers start melting away, and that's what I'm kind of crossing my fingers about for multi-family dimensional. And my MedPeds friend here will figure it out together.
Yeah, and I think for me, in my previous role, that's some of, I was part of the whole compliance process at Tulane, and so, you don't want to piss off the compliance officer at your university, at your organization. So, making certain that you're asking them. My point to some of this is that this is a question that we're going to try and get answered in the white paper, so that we've got an answer from, our compliance departments maybe. And that is always the problem. It's sort of like IRBs, right? Even within, IRB at your site is going to have very different opinion from another site and very different opinion from my site. And even within IRB, within your own IRB, people are going to have different opinions. We're about 10 minutes of. We're going to close this out. I do want to, just ask each of you one quick question. The single thing that you think, I know this is the worst question in the world, the single thing, the single best piece of advice from your period of doing this, 4, 5, 6 years now, that you could say, this is what really was the tipping point for us. I'm actually going to start with you, because I think my question to you, Joette, is what is the best piece of advice you could give us in how we interact with, get in touch with, get access to promoting our brand?
I think that having that wonderful relationship with your PR person is a great place to start. If you get pushback or there are barriers, then I would go to the next best place. It might be marketing, honestly. Or if you need to, you can go outside. There are PR firms out there, but again, if you're in a corporate setting, you have to make sure that you're doing everything within their guidelines. I think that this story sells itself. It's a wonderful story, it's positive, and it's showing that the community is involved. So I think that if you reach out and you don't get a good response, then don't be discouraged. Reach out again. A lot of times people are very busy. Reporters have lots on their plate. And it may mean that they said no this time, but the next time they're going to say yes. And if they say no the next time, then just try again.
Yeah, a reporter told me once that, if you're standing at the door when the reporter needs that topic, they're going to choose you, right? You're the guy. But if you're not there in front of them when they need something about that topic, and so a lot of it is just being present all the time.
But, introducing yourself and letting them know that you're out there, when that opportunity comes up, they may remember you. So, you're on their mind, but you have to be ready to act very quickly. A lot of times they're on extremely tight deadlines.
So that gave y'all some time to think. I think Joette had the easy question. That gave you guys some time to think. What's the tipping point for you? Where did you see it changing?
Can I be kind of lame in my response
of course.
and say it's been probably a lot of cumulative wins along the way. So Tim and I were reminiscing last night. He knows several members of our team. I think initially it was putting the big idea out there and finding the people that could be your greatest allies in the work. From there, it was having success in submitting a grant proposal and receiving funding for that and really doing our best work in that space for a long time. There was a moment when a physician approached me and she said, "Yeah, I saw you guys start your program and I didn't really know, what this was going to be all about, but you've been around for 3 years now, so now you're legitimate." So it's hearing those stories that people start to recognize the work that's gone in. I would say after that was executive support for a business plan, and from there we're constantly pushing the envelope every step of the way. So we have not arrived. We have not solved this big problem, and I still think that financial ROI is still really challenging to prove. So I think collectively we're all going to need to do that together.
So I'll reflect back some of our conversation at dinner last night, if that's okay. One of the things that we talked about, because we kind of were reminiscing as Kristi said, that you were there. You just kind of kept going to meetings and kept going to meetings and kept going to meetings and kept showing up and kept showing up. I think it's very analogous to being in front of the reporter all the time being there and people knowing that you're serious. So I think that persistence piece just makes a big, big difference. Yeah.
So I think what I want to share actually dovetails nicely into that, because the persistence, the dogmatism that it takes, the blood, sweat, and tears, which is what I say all the time, this is a passion project at the beginning for almost everyone. So what is the most important thing that you do is you figure out how to take care of you. And you cannot be passionate and showing up and dogmatic and consistent and thoughtful and creative and innovative if you haven't figured out how to be well yourself and how to be inspired. And so for me, it's just simply lifestyle medicine for myself. And I'm in that 10-year period where I finally think I've recovered from having my children and the sleep deprivation of those early years, and I've recovered from training, and I've recovered from the fact that it was supposed to get easier when I became an attending and it didn't. All of those things. And it was sleep. It was movement. It was, what I shared yesterday, that instead of drinking, I was going to exercise, or all the little stuff. So you need to say, what is it that you need for yourself? Because when you view yourself as a victim of the broken system, you will never get the creativity to move past it. So I had to stop seeing myself as the little primary care doctor who no one takes seriously because she looks too young. And I had a department chair who's no longer a department chair anymore because he's retired, but he would jokingly tease me in the hallway and be like, "Are you still doing that silly cooking stuff?" I mean, totally not taken seriously. And so how do you find the momentum to keep going? You believe in yourself. And that only happens when you find your team, you find people like Millette who drag you off the ledge when you're on the ledge, who say you need a vacation, and you go to conferences and you read books and you do something fun and inspiring. So if you don't know what that is for you, start there, because you have to have your attachment to the electricity outlet to keep getting energy, and that's the only way to keep going. And there's times when you just disconnect completely and reset.
My colleague Mark Kahn, who was the dean of students at Tulane, Mark and I used to ride bicycles together on the weekends, and we were really pretty close. And he's now the dean of the UNLV, the school in Las Vegas. And Mark, when told me, good friends tell good friends the truth, right? They don't always tell them the truth immediately. And Mark said that when he first heard we were going to do culinary medicine, he said he thought to himself, "Oh, that's cute." Right? And we deliberately, I guess we were probably 2 years in, we deliberately started inviting faculty members who might not otherwise have an interest. And all we said was, come to the class. You don't need to come for the whole 3 hours of the kitchen component. We opened the instructor resources to them so they could see what that class was going to be. We opened the student resources so they could look at the video lecture, et cetera, and review the quiz, the reading. If they wanted to come for the whole class, cool, come and cook. But if you just want to come for the table discussion, if you just want to come for the case study, come for the case study, bring your expertise. And we ended up with this cadre of nephrologists and physiologists, and so you'd be doing the renal module, and you'd have a renal physiologist and a nephrologist there in the room with the culinary medicine specialist and a dietitian, and a fourth-year med student who is really well versed in the programming now. And people began to get it. And that's Mark Kahn came and did that. And that's when he came back and he said, and he told me, I thought this was cute, but he really did begin to see this, that it's a very serious clinical enterprise for us. And I think that can be the tipping point, is just showing people that, that we're taking all of that stuff that our med students, we're teaching them right now, physiology, biochemistry, metabolism, etc., that they're learning in the preclinical years and translating that into the conversation that they will have in the examination room with their patient about food. Not about weight loss, not about monounsaturated fat, calories. Our patients don't know what calories are. And I think that was, for us, a lot of the tipping point at Tulane. While we had a lot of support from day one, because it's medieval England, the king gets what the king wants, but at the same time, we really began to have broad support because we involved people who might not otherwise have been involved and may have just thought it was cute. And it is cute, but it's also important.